This is our positioning video for the cervical spine under spinal precautions.
In this demonstration, we will be performing the AP and lateral projections.
We will show modified positioning techniques to maintain cervical immobilization throughout the procedure.
And we will discuss technical factors and evaluation criteria for those views. But first, we need to get ourselves a patient.
To start with the APC spine, the patient remains supine on the stretcher or table with the cervical collar in place. Do not move or manipulate the neck. Ensure the patient's head is straight with no rotation. If possible, gently adjust the body, not the neck, to align the mid-sagittal plane with the midline of the table and IR. If the patient needs adjustment, ensure that there is someone stabilizing the neck and collar at all times. Direct the central ray to C4, approximately at the level of the thyroid cartilage, with a 15 to 20 degree cephalic angle to open the intervertebral disc spaces. A 40-inch SID is utilized for the AP axial C-spine.
Collimate to include from C3 to T1 and laterally to the soft tissue margins of the neck. Normally, this is an 8-inch by 10-inch field with a larger field required for larger body habitus, or to ensure the complete collar is in the field of view. The image should demonstrate C3 through T1 with open intervertebral disc spaces and no rotation, indicated by symmetric lateral masses and spinous processes aligned midline. Use shielding when appropriate, ensuring it does not obscure the anatomy. Shielding is used especially in children, pregnant women, and males and females of reproductive age.
Apply a technique of approximately 65 to 75 kVp and appropriate mass via AEC for adequate penetration. If setting manually, 8 to 12 mass is normally used. A grid is typically used due to body part thickness, but in instances of severe trauma, we can use a tabletop or portable image receptor. Place the anatomical marker on the side of interest, clear of anatomy, instruct the patient to hold still, and suspend breathing during exposure.
This is the left lateral cervical spine cross-table projection used in trauma with spinal precautions. Place the image receptor vertically at the patient's shoulder. Gently pull the shoulders downward if possible to visualize lower cervical vertebrae without compromising patient safety.
Direct the central ray horizontally to C4 at the level of the thyroid cartilage. A 72-inch SID is utilized for the lateral, but in instances of limited equipment mobility, 56 or 40 inches can be used. Ensure that there is very minimal oid to reduce magnification. Collimate to include from the base of the skull to T1 and from the anterior soft tissues to the posterior spinous processes. A typical field size of 10 inches by 12 inches is used. The image should clearly demonstrate all 7 cervical vertebrae and the C7 to T1 junction. There should be no rotation with superimposed posterior vertebral borders and open intervertebral foramina. Soft tissue structures should also be visible.
Again, use shielding if it does not interfere with the anatomy. Technique is typically 75 to 85 kVp with adequate mass for lateral penetration. A grid is required for this projection due to the thickness of the shoulders, but if a wall bucky cannot be utilized, a stationary grid or grid cassette should be placed behind the patient to reduce scatter radiation and maintain image quality. Ensure the marker is placed on the correct side and orientation. Instruct the patient to suspend breathing and remain completely still during the exposure.
Always prioritize patient safety and spinal precautions in trauma imaging. Do not remove the C-collar unless cleared.
You got that?
Like, what the fuck? How are you supposed to do this, bro?
That's good enough.
Oh my god.